So I'll start off with the first topic, that is best practice SOPs for optimal refractive outcomes. In this presentation, I'm going to share with you the protocol that I follow for IL power calculation in routine eyes and in most of the difficult situations. So this is actually not a fixed protocol. It keeps on changing depending upon newer information, more experience that I gain. And this is a very happening field. If you take every issue of the peer review journals, each issue will have multiple articles, as you see here. So which means a lot of things are happening, and we need to be aware of what are the new things that have come up, what are the new experiences that our peers have shared through these publications, and whatever is effective, whatever is practical in our setup, so that needs to be incorporated in our IL power calculation exercises. And we, being the surgeons, have to determine what is the best for us, and this has to be passed on to the team which does the IL power calculation. So where do we stand today? There was an article by my good friend from Italy, Giacomo Savini, where he reported his results on IL power calculation in routine eyes, measured using a sweep source OCT based optical biometer, a high quality optical biometer. And he showed that 88% to 90.67% of the routine patients, when they are worked up with the newer formulas, should rank within a refractive prediction error of 0.5 diopters. So if you are not reached that level, you have a long distance to cover, and you have to do your basics properly. And those of us who have already reached this level of accuracy, what next for us? So many people feel that perhaps we have reached the limit. Axial length calculation measurement has become very precise and accurate. There is some issues still pertaining with the keratometry. We still have to go a little distance with precision as far as keratometry is concerned. And there are certain uncertainties that we cannot do anything in our surgical steps. For example, the discrete IL power steps, we have no say over it. Manufacturing, labeling tolerances of the intraocular lens. Effective lens position is again a bugbear. And we are increasingly realizing that angle kappa and ocular biomechanics also play an important role in IL power calculations. So a brief word about this, there's ISO standard for labeling tolerance. So, ISO allows the companies to have some amount of inaccuracies in the power that is printed on the lens package. So if a lens is less than 15 diopter, then there is variation between minus 0.3 to plus 0.3 diopter. And for higher lenses, for thicker lenses, it could vary from minus 1 to plus 1 diopter. So the lens that you get, that is actually may not be the precise power. It lies within that range. So that can result in some inaccuracies in the postoperative prediction error, particularly for thicker lenses for higher power. And then most of the manufacturers come up with steps of 0.5 diopter, 20, 20.5, 21. And for the extremes of the eyes, it could be even 1 diopter. So there again, you may not get the desired lens. Whatever lens you are opting for, you may not be able to get that particular lens. All of us must realize that IL power calculation is not something that one does just before the cataract surgery while working up the patient. It is something which transcends in all stages of the patient's surgery experience. Preoperative period, intraoperative, the surgery has to be done properly, rexis has to be well centered, and postoperative period is where you do the auditing. And you can put it for 10 minutes. You have to do the auditing to find out whether whether you're able to reach the target refraction. If not, how far you are from it, and what are the modifications you have to make in your protocol. We have known for last 7-8 years that ocular surface plays a very important role in IL power calculations for particular measurements. So first thing that we look for is the presence of ocular surface disease, and if it is present, it is the biometry is not done. We try to use lubricants to optimize the ocular surface, and then the biometry is repeated after a few weeks, and if necessary, even after some more weeks, so that we can accept only 2 consecutive repeated values. Then we know that our biometric evaluation has been pretty precise. We must employ a nil touch technique of biometry. Biometry should be performed on a virgin cornea. So if a patient has already undergone gonioscopy, apprehension tonometer, dilated evaluation, it's no longer a pristine cornea. So in that situation, it is a good idea to bring the patient back on another day to perform the evaluation. Most of the biometry is performed without the pupil being dilated, but certain situations for ultrasonic biometry as well as for optical biometry, like this was published in JCRS with biometer was IONmaster 700. About 8.52% of the cataract surgery patient did not give good quality measurements. So once these eyes were dilated, most of them could give a good measurement. So there is some need for, we need to dilate certain patients to get a high quality measurement. But then there is another side to this story. Once you dilate the pupil, there are changes in the biometric parameters that happen. And these biometric parameters which you obtain after dilatation may alter the IL power calculation to that. In fact, in about 20% of the patients, it could result in a myopic error of 0.5 to 1 diopter. So this is something which is discussed with the patient before the biometry is done, before the surgery is done, and then the patient is taken up. This is what all I use for my biometric evaluation. I use a topography. This is must for toric IL and for higher the newer generation intraocular lenses. Eye trace also helps you to rule out certain cases for these advanced technology lenses. Now, once you have got very precise biometric parameters, you need to use a particular good formula. So these are the formulas we have been using for last couple of years: Barrett Universal 2, Heal RBF, Olsen, and then there are new kids on the block: Kane formula, EVO, Panacea. Beginning of this year, there was another classification. I think it looks very, very intimidating, but it is a very systematic classification. I'm not going to go into it, but so there are a lot of formulas that are available, and I always do an online calculation. I don't depend upon the IOL formulas which are there in the particular biometer. So online IOL calculation means you can calculate your lens power using all these online calculators, and that means you can get multiple results. And also the updates are incorporated in the formulas by the formula writers as soon as the updates are ready. So you have a very up-to-date formula, unlike the formulas which are there in your biometric devices, where the updates may not be, A constant may not be updated, or other updates may not have been incorporated. So go for an online calculation. And these are all most of these calculators are absolutely free of cost. I'm not going to spend much time on it. Toric formulas and SI calculators. Post-refractive calculators, I think Ascaris calculator and is most complete. Barrett and Pearl DGHS also. So this takes care of all your post-refractive surgery requirements, including post-RK eyes. So a word about Hoffer Q. Many people have been using Hoffer Q, but in fact, in my personal discussion with Ken Hoffer, he told me that Hoffer Q is something which he wants to people to abandon, but then people won't do it. So he updated this formula, Hoffer QST. So it has updated algorithms, including artificial intelligence. It has taken gender into account, and there is preoperative anterior chamber depth. And this is also incorporated in the ESRS site. I'll come to it later on. So my go-to formula is Barrett Universal 2. It is there in the APACRS website. It gives you the entire Barrett suite. I actually use a Barrett toric calculator for all my routine cases. And then Barrett TrueK formula and Barrett TrueK toric calculator for post-refractive surgery eyes. So all your IL power requirements can be satisfied by Barrett suite of formulas. And Heal RBF formula, of course, is an artificial intelligence-based formula. It is available in Warren Hill's website. It is also available at the ACRS website. You have the Heal RBF version 3. But still, it may not give you the full, some of the extremes of the eyes, you may not get proper, values. It may give a red flag. So then of course, I would also be using the other calculators and find out and compare in extreme situations what should be the IL power that I choose. Kane formula has been doing extremely well. The non-toric version, toric version, and recently the keratoconus version has also done extremely well. And this is proved by multiple studies that have come up in the peer review literature. Second eye enhancer is another feature which has come up in the Pearl DGS calculator. This is something which I want you to be aware of, and I use it extensively. Out of the cataract societies, European society was the only one which did not have an IL calculator. So 2 years back, they came up with an IL calculator, and for non-toric lenses, there are 7 modern formulas that can be made use of, so to get your IL power. So here it is very simple. You just input the data in the fields only once, and this website on its own approaches all these 7 calculators and gives you the result in one printout. So for example, now say if I choose a 16.5 diopter for a particular formula, Barrett formula, so I have an idea as to what is the prediction error shown by, refractive error shown by the other formulas. So previously, I had to deal with multiple printouts, different formulas, and it was quite cumbersome and it was quite laborious. So this has been sorted out by the ESRS calculator. And for the toric version also, ESRS calculator uses these 4 formulas, and it is again proved to be very, very effective. Another strategy that I use, for better prediction for the second dial. First eye has been operated, second eye is being taken up. So if there is a residual refractive error in the first eye, so I would wait for about a month or 2 to make sure that this is stable. Then I would use I would tinker with the IL calculation in the left eye, so that on the fellow eye, the second eye to be operated, I would use about 0.3% of the refractive error, so refractive surprise that was seen by changing the power of that eye. So as I mentioned earlier, second eye enhancer is available in per Regius calculator. Increasingly, we have realized that the gender is playing an important role in these IL power calculations. Barrett Universal 2 is most accurate for males rather than females, and other formulas seem to be more accurate for females than males. And these gender differences are more pronounced at extremes of anterior chamber axial length or anterior chamber depth. So friends, and I mean, you must realize that the cutting edge instruments and devices play a very important role. You must use the current formulas. Lens constant optimization is also important to a large extent. But at the end of the day, you are in charge, so you should work up your patient properly, use appropriate measurement devices. Anything that comes up in the market makes a lot of noise, may not be the best device. So you be very judicious in the selection of biometric devices that you use, and work with properly optimized lens constants, and strive to use all available resources to their best advantage. So this is the SOP that I follow for all my IL part for my cataract patients. This has given me good results, and this is quite variable. It keeps on changing, maybe every few months, depending upon my accumulating experience or the information that I learn from the journals and from my peers. I keep on changing. So thank you very much for your kind